Good morning everyone, my seniors, my colleagues and my juniors. Today I am going to present on a topic of technique of pancreatitis, duct to mucosa, following the Whipple's procedure in a small pancreatic duct. 10 days back, we operated on a female, Miss Giri, 26 years female, married from Bhutan, Nepal, who initially had a history of trauma, who was hit by ox 1 month back. And during the evaluation for that trauma, there was an incidental finding of pancreatic head mass, and for which she was referred to our center. She had no comorbidities, no history of smoking or alcohol consumption. On examination, her ECOG score was 0. She was fair looking, no pallor, no icterus, no lymphadenopathy. She had per abdomen examination was soft, non-tender, and no obvious mass was felt. And she had undergone ultrasonography of her abdomen in another center, which showed there was a homogeneous solid lesion in the head of pancreas of about size 3 into 2.2 centimeter, and with no lymph node around the mass and no adhesion, and thus was advised for CT abdomen and pelvis. And she then underwent CECT, contrast enhanced CT of abdomen and pelvis in another center, which showed there was a well-defined mild homogeneous enhancing round to oval hypotenuse lesion in the head of pancreas of about 2.6 into 2 into 2.1 centimeter. The mass was abutting the confluence of the portal vein, but it was maintaining a fat plane between the portal vein and the lesion. And also there was a finding of right adnexal complex cyst, which was more likely of being ovarian hemorrhagic cyst. And this is the, we did not have the DICOM file, but the CT film was present, and here we can appreciate the mass mentioned above. And then we evaluated her pre-op investigation, which was fairly normal, and also her CA 19.9 was very low. Then we planned for Whipple's procedure, SMA first approach, with a diagnosis of very solid pseudopapillary tumor of pancreas. And during the intraoperative procedure, we noticed a firm mass of about 2 into 2 centimeter in pancreatic head, which was encapsulated and no invasion of the serosa. And the duct size was only of about 1.5 mm. And the OT duration took about 5 hours 40 minutes, and the blood loss was about 250 ml. And the fistula risk score according to this becomes 6, since the pancreas was soft and it was ampullary lesion, and the size of the duct was only 1.5 mm, and it becomes the moderate risk for the fistula score. And the histopathological examination of the specimen is awaited. And here is a small video of the procedure. We started with the chevron rooftop incision for the procedure. Then the generous cauterization was done with the uplifting of the duodenum and the visualization of the inferior vena cava and the left renal vein. And with the generous cauterization, then we proceed towards the visualization of the superior mesenteric artery, so that we can assess for the resectability of the tumor. And after the visualization of the superior mesenteric artery, here we can see this is the inferior vena cava, and this is the aorta, and this is the outlet of the superior mesenteric artery. After the proper dissection, the tumor was resectable, thus we proceeded for the Whipple's procedure. And after this, we proceed with the Catterback maneuver, and the dissection of the gastrocolic trunk of Henle was done, and this was tribodic type of gastrocolic trunk of Henle. We can appreciate this is the right gastric vein, right gastric superior vein, and this is the anterior superior pancreatic vein, and this is the right superior colic vein. And the ligation of these 3 vein were done, and the proceeded, and then we further proceeded along the superior after the identification of the superior mesenteric vein and the superior mesenteric artery. Then we went along the dissection through the tunnel of loupe, dissecting the uncinate process from the superior mesenteric vein and the superior mesenteric artery. And we did a generous dissection and the meticulous dissection with the bipolar cautery. And after some point, we went above in the hepatoduodenal ligament, and we dissected around the hepatoduodenal ligament and dissected the right gastric artery and the gastroduodenal artery, and ligation of the right gastric artery and gastroduodenal artery was done. And then the thorough tunneling was done to the tunnel of loupe, and we separated the gastrectomy. We usually perform the non-pylorus preserving gastrectomy, and then after the separation of the stomach, we then transect the pancreas with the monopolar cautery after taking the two-stage suture, and this is a transection of the cautery. And after the transection of the pancreas, we then proper dissection around the common hepatic and the bile duct. We ligate the common hepatic duct, and then we proceed towards the transection of the common hepatic duct and the en bloc removal of the Whipple specimen. And in this case, since the patient had small pancreatic duct of about 1.5 centimeter millimeter, which we measure with the infant feeding tube, we then usually in our center we perform the serial dilatation of the small main pancreatic duct. After the serial dilatation, then only we proceed towards the pancreatogenestomy with the modified Heidelberg technique. In this case, the duct was of about 1.5 mm. Thus, we started the dilatation with 5 French infant feeding tube, and then we gradually increase the size of the infant feeding tube from 5 French to 6 French, then to 7 and to 8 French, keeping the keeping the infant feeding tube in the main pancreatic duct for about 2 to 3 minutes. And after that dilatation, we then start the modified Heidelberg technique for the pancreatogenestomy, and in this case we use the loupe for the proper visualization of the duct and the proper anastomosis. We perform the modified Heidelberg technique in 4 layers: posterior interrupted layer, and then duct to mucosa, also 6 to 8 interrupted suture with 50 monosin, and then anterior margin, anterior pancreatic parenchyma in the interrupted layer. And in the here we are taking the stage suture over the pancreatic duct. We took about 6 interrupted suture in this case, since the duct was small, and then after taking the stage suture we kept it securely. Then we started the interrupted suture over the jejunal seromuscular layer and the posterior pancreatic parenchyma. We took the interrupted suture in the posterior parenchyma, and only after this we made the jejunal window. And after the making the jejunal window, the suture which was kept secured, the stage suture over the pancreatic duct, we then gradually took the posterior full thickness jejunum of the jejunum, and then gradually we ligated the suture, tied the suture. And after the posterior margin suture has been done, we then keep the pancreatic stent in the pancreatogenestomy site, and only after that we do the anterior margin suturing of duct to mucosa after taking the full thickness of the jejunum. Only after this we secure the anterior margin, and here we are doing the anterior margin full thickness jejunal and the pancreatic duct to mucosa suture. And we usually do with the 50 monosin in our setting. And after the finishing the duct to mucosa suture, we then proceed to the anterior margin. We take the seromuscular layer of the jejunum, anterior jejunum, and the anterior pancreatic parenchyma. And this is also we do in the interrupted fashion, and we are ongoing with the suture. And after the securing all the suture, then we proceed towards the hepatogenestomy. And with the hepatogenestomy, in this case the size of the duct was very small, of about 5 mm in size. Thus we decided to go with the interrupted single layer suture, and also we kept the stent because the size of the common hepatic duct was very small, and the single interrupted layer of hepatogenestomy was done. And after the completion of P-J and H-J, we did the gastrogenestomy, and the closure was done. And this is the in bloc specimen that we retrieved after the procedure. Now, ongoing with the introduction, pancreatoduodenopathy or Whipple's procedure. It is a commonly indicated procedure for the either benign or malignant lesion over the pancreatic head and the ampullary region, and the operative mortality in relation with the Whipple's procedure is about 2 to 3%, which has decreased in the recent decades. But the post-operative morbidity still remains significantly high of about 30 to 50%, and among them the main cause is the post-operative pancreatic fistula, and the incidence of the post-operative pancreatic fistula is of about 5 to 30%, and it is also associated with the serious complication like systemic sepsis, organ failure, and post-pancreatectomy hemorrhage, and even death. So far, various attempts is made to reduce the occurrence of post-operative pancreatic fistula, but no single measure has shown to be consistently superior to one another. Soft pancreas and the non-dilated main pancreatic duct are the significant risk factor for the development of the post-operative pancreatic fistula. And with a small pancreatic duct, various technical challenges like increased risk of anastomotic failure, pancreatic fistula, and difficulty in precise suturing due to the small duct size, the risk of anastomotic stricture leading to exocrine insufficiency, and also the need for the specialized technique to prevent the complication are associated. And here are some literature. This is a classification given by the International Study Group of Pancreatic Surgery, which has divided the pancreatic texture and the pancreatic size, and categorized the size and the texture in relation to the post-operative pancreatic fistula percentage. And it is categorized as grade A, grade B, grade C, and grade D. And the first A is the non-soft pancreatic texture, and the non-soft means any hard form or any sclerotic pancreatic tissue, which is usually done during the intraoperative period by the surgeon, by the feeling the pancreatic tissue by the surgeon himself. And the main pancreatic duct size more than 3 mm, and non-soft pancreatic texture with the main pancreatic duct size less than or equal to 3 mm. And C is the soft pancreatic texture, that is soft, brittle or febrile pancreatic tissue texture with the main pancreatic duct size of more than 3 mm, and soft pancreatic texture with the main pancreatic duct size less than or equal to 3 mm. And the rates is gradually increased with this grade, and in the class 1 the percentage is gradually the POPF gradually increased with the class of the classification, and it is highest in the soft pancreatic texture with main pancreatic duct less than and equal to 3 mm. And the post-operative pancreatic fistula grading, which was given by the IPGSG, there are 3 grading. Grade A, that is biochemical leak only, which is now not considered as a post-operative pancreatic fistula, and grade B and grade C. And grade B is the post-operative pancreatic fistula where the patient is not undergoing any mortality, or any reoperation is done for the pancreatic post-operative pancreatic fistula, is categorized as grade B. And grade C, where the patient has either experienced death or also need reoperation for the post-operative pancreatic fistula. And also the serum amylase level is more than 3 times the upper institutional normal serum amylase level, and other features are described in this table. And this is an article which was given recently in 2020, and it has mentioned many techniques, modern techniques of pancreatogenectomy, and it mainly focuses on 2 topics, that is duct to mucosa anastomosis with these various modification like modified Heidelberg technique, modified Brungard technique, and modified Katika techniques, and another one is the invagination technique and its various modification like donking. And in the duct to mucosa technique, moreover the either with whichever modification, the basis is the the duct to mucosa technique, which are usually done with the fine absorbable suture of size about 6 to 7, and in some cases they use internal pancreatic stent, which is optional, and the precise duct to mucosa suturing is done, and layer closure with the additional cerebromuscular stages is done. That is also variable with various version. And invagination technique, where the duct to mucosa anastomosis is not done, but the pancreatic stump is invaginated into the jejunal mucosa. And though the invagination technique is simpler, but a higher risk of exocrine insufficiency is seen. And in this article, the it is more favored that duct to mucosa anastomosis is better than the invagination technique in a small duct and also in various soft pancreas. And this is an article which was done in China. So they have studied what the size of the pancreatic duct is safe for duct to mucosa pancreatogenestomy after the pancreatoduodenectomy. In this article, it has categorized the duct less than 1 mm and more than equal to 1 to 2 mm. And they have mentioned that there is a the postoperative pancreatic fistula is more in the duct, that is more than 1 mm, and it has concluded that duct to mucosa pancreatogenestomy can be safely performed for the pancreatic duct which are more than 1 mm and without any significantly increased risk of POPF risk. And this is another article. This is done for both laparoscopic surgery and also for the small size main pancreatic duct, and they have take about 63 cases, and 38 cases underwent laparoscopic surgery and 26 cases were of small pancreatic duct, that is less than 3 mm, and they have done the modified Blumgart technique for the anastomosis. Sorry, not in this case. They have taken the modified double purse string continuous suture technique for pancreatogenestomy, which I have illustrated here. What they do is first they take stay suture with the jejunum and the pancreas, and they put a purse string suture around the pancreatic duct. And after the placement of the purse string suture with the pancreatic duct, they then anastomose the posterior pancreatic margin of the pancreas with the jejunum in the continuous fashion, and after that they put a suture over the pancreatic tissue, and then they do a purse string over the jejunum window, jejunal opening they have made, and after the purse string they again took it back to the pancreas and they make an anastomosis. And for the anterior closure, they take a continuous suture over the anterior pancreatic parenchyma and the jejunum. And in this case also there is a decreased POPF with this type of suture, and they have done this suturing laparoscopically for the small pancreatic duct. And another is duct to mucosa pancreatogenestomy for small main pancreatic duct and soft pancreas in minimally invasive pancreatoduodenectomy. Since the classical Heidelberg and Blumgart technique is difficult to do in the laparoscopic and the robotic setting, in this case they have what they have done is they have taken only 2 suture over the duct to mucosa, and after that they take a whole through and through penetrating suture to anastomose the pancreatic parenchyma and the jejunal cerebromuscular layer in the setting. And there is also the shown that there is this can be a good alternative in case of the laparoscopic and the robotic cases, and there is less, only 4% of the case have the grade B POPF and no cases of grade C POPF has been in cases out of 98 patients. And then in the for the open Whipple surgery, there is another. This is also done in China. They have done advanced ligation to facilitate the pancreatogenestomy following the pancreatomy for dilatation of the main pancreatic duct. What they have done is after the transection of the pancreas, they have done the advanced ligation of the whole pancreas, and also this. They have taken the whole of the pancreas before transecting. They do the advanced ligation of the pancreas with the pancreatic duct in situ, and they preoperatively select the case of the small size pancreatic duct, and they initially also assess with the CCT and also the ultrasonography the size of the pancreatic duct, and they select the case with the small size pancreatic duct that is less than 3 mm. And during the operation, they after the dissection around the pancreas and before the transection of the pancreas, they put the advanced ligature around the main pancreatic duct and the pancreatic parenchyma as a whole without disturbing the pancreatic tissue. And then after they also record, they do intraoperative ultrasonography and see for the dilatation of the pancreas. And the mean time for the pancreatic duct dilatation in this study was 43 minutes up to 134 minutes. And on ultrasonography, after the dilatation of the duct, then only they transect the pancreas and immediately they put the pancreatic stent so that the pancreatic duct don't shrink again. Then only after they do the pancreatogenostomy. And another is the use of stent. In this article, this also in Japan, what they have done is they have used a long internal stent. What they do is after the pancreatogenostomy, during the pancreatogenostomy, they put a long stent over the pancreatogenostomy site, bringing that stent up to the Brown's anastomosis and through the same jejunal limb that is used for the hepatogenostomy and then gastrogenostomy. In their study, they have not found very much, no significant difference between the cases kept with short stent or the long stent, and so no much difference is seen. And also the cases where the long stent has been kept, there has seen the chances of infection or intraoperative postoperative infection is the rate of the with the complication of the stent is seen. And another is this externalized trans-anastomotic stent. As previously mentioned, that was internal stent, and this is the externalized trans-anastomotic stent, where they keep the stent over the P-J site, and after they take that stent out of the same jejunal limb outside to the skin. Also for the drainage of the pancreatic juice outside the limb. And in this case also they have not found much difference between the cases with no stent and with the stent. Rather, the blockage of this externalized trans-anastomotic stent is higher. And another is a recent article where they have taken 72 cases where they have kept coronary artery stent at the pancreatogenostomy site, and as per them, none of the case have the migration of the stent, which they have seen postoperatively in the day 5 and day 10 assessment has been done, and no grade C pancreatic leak has been seen, and the mortality is only 0% and the POPF rate is only 11%. I could not assess the whole full article of this case, so only the abstract here is present. And another is a case. This is a study done in Kolkata, where they have similarly like our case, they have dilated the small pancreatic duct with infant feeding tube, with gradually increasing up to the 12 French infant feeding tube, and each case they have kept for 10 to 15 minutes, and they have enrolled about two groups were kept, one with pancreatic duct. They have selected the pancreatic duct less than 3 mm, and they have kept two group control and the case with duct dilatation, and they have done the Blumgard technique for the anastomosis. And they have also mentioned that after the dilatation, the postoperative pancreatic fistula rate has been lowered, and thus intraoperative on-table sequential dilatation not only helps in the easier anastomosis but also helps in decrease rate of postoperative leak and also the mortality. And this is not an article, but I found this on YouTube. This was This was also done in India by in Kolkata hospital by the Kolkatan surgeons, where they have used a small urethral metal curved dilator, which they have inserted into the small pancreas, and which have helped them to do the anastomosis between the pancreas and the jejunum. They have also done Duct To Mucosa. We can also see this in the YouTube. And as in the conclusion, pancreatogenostomy after Whipple's is challenging with a small duct, and till now Duct To Mucosa anastomosis remains the best approach whenever it is feasible. And in the advances with the surgical technology, we continue to improve the outcomes and the reduce complications in the small pancreatic duct. Thank you. Any queries?
Thank you, Dr. Sasi. It was really a very nice presentation. So actually the reason behind this presentation were few things. First, it's not uncommon to find very small pancreatic duct during the Whipple surgery. So the emphasis today was to how do we do the Whipple surgery. The first emphasis goes that is the SMA approach. The question is not the SMA approach for the lymph node dissection, because this is just simply a spin, not a malignant case. So therefore there is no role of lymphatic dissection in this particular case, but we do the SMA first approach for the ease and also to proper identification of some arterial anomalies. We can properly identify the IPD, etc. So it's very good technique. I think wherever is the location of the tumor, not essentially the malignant lesion, but we always go for SMA approach for the proper anatomical dissection and arterial anomalies. What we find, now we enjoy the technique because we can identify each and every structure which has been defined in the book of anatomy. So this is the first reason that we went for the SMA approach, and that's the standard practice in our unit. Second thing, regarding the duct to mucosa anastomy, there have been various literatures, various things have been said that if the small duct is not safe to do the duct to mucosa. So this video very well demonstrates the duct size was very small, but we can still perform whatever is the size of the duct, which has been also declared by various literatures that you have already said, that even whatever is the size of duct, even less than 1 mm, they do not recommend in this some of the literature, but we can do with the loupes. So therefore, if the duct size is very small, then we have two options. The standard practice in our unit is to do the serial dilatation as has been shown. So the serial dilatation has got two purposes. First, we can make intraoperatively dilate the duct. The only thing is that we are afraid of the postoperative pancreatitis. So far we have got 20 patients prospectively reviewed. We have been doing since last 5 years the similar serial dilatation, but we have not kept the record of what was the incidence of postoperative pancreatitis because of the stent. But so far now we have been doing the prospective study, so we haven't found so far any postoperative pancreatitis related to the stent insertion or dilatation. So I think that the larger number of samples we have to wait for the results. The next very important thing is that after serial dilatation we can achieve some sort of dilatation. It will be easier for us to make the anastomosis. And a very important point in this particular case was that for the smaller ducts we can do, it's very good to do with the magnification. Like in this particular case we use 3.5x magnification with the loupe. So definitely if smaller duct we can even not dilate it, we have the option of just simply suturing under the loupe. But for us who are not a very good, who are not a plastic surgeon, so I think it's a good habit to both dilate and do under the loupe the P-J anastomosis. So this was demonstrated very well in this particular case. So our recommendation goes that for a smaller ducts you dilate it if possible. If not, you can do under magnification with the loupe. It's very good technique, and you can insert very particular, precisely all the sutures. If you do with the naked eye, maybe you can cause the stricture of this anastomosis that may cause in one hand the POPF, the other hand it may cause the exocrine insufficiency in the future. Therefore, things can be avoided by proper placement of the stitches under magnification. You can use not only 5 0, you can use 6 0, 7 0 sutures also. This was the next thing. And also, very well said by you that some of the surgeons, like in Japanese, they do the ligate the pancreatic duct in order to make the duct dilate. So this technique was basically quite simple, not ligation, but we can do it simply with the ribbon gauze, clamp or just tie the whole pancreatic tissue and block before transection. Wait for some times. That is very regularly followed up. Being done at the Palani Value Center in Coimbatore. So they have been routinely doing ligating. Just clamping the whole pancreatic tissue with the ribbon gauze in order to make the duct dilate, and that will be easier for them for the reconstruction, particularly in the laparoscopic cases. So, and regarding the stent, if the duct is very small, then it may not be wise to put the stent because they may cause the obstruction of the duct itself. But if you can dilate, then it's good. Our habit is to put the stent not for the purpose of prevention from the PUPF, but to place the anterior stitches properly in order to avoid the posterior layer to be taken in the bite. So our recommendation is, our conclusion from this video, this was very nice video, is that duct to mucosa is the way to go. Small ducts can be done with the duct to mucosa anastomosis by the serial dilatation. If needed, we can add with the loupe magnification and the anastomosis. So any comments, Dr. Sagar, Manoj, Srijana, Sandeep? Mike is yours.
Yesterday Sandeep asked me about why I did beveling of the pancreas while transecting of the pancreas. Actually, the beveling, the technique of beveling during pancreatic jejunectomy while taking the posterior row is to create a goopy fish mouth so that the jejunum will be buttressed to the pancreatic posterior surface of the pancreas, as well as there will be anterior buttressing, as well as sidewise buttressing will be there. So that was the basic technique. Otherwise, no comment from my side. Dr. Manoj, do you want to comment?
No comment.
Okay, thank you.
So pancreatic not easy practice. So why is PG not so much practice these days? PG, sir, pancreatic gastrectomy.
Pancreatic gastrectomy. I think my personal view is regarding the PJ or PG, whatever, or technique of anastomosis, is the way you are comfortable with should be done. If you are used to do the PJ, please go with the PJ. If you are used to do with the invagination technique, please go with that, because it's not so common procedure. It's a very complex procedure. Once the complication happens, that may lead to the mortality. So therefore, my proposal or my opinion is that whatever you are comfortable with, which technique, you please go with that. So in my hands, I think the PJ is the better and the easier to perform, so I always go with the PJ. In our center, at least we do for PJ, but definitely the randomized trial has shown that PG or PJ both are equivalent. Indeed, there is a point, if we have done the PJ and now there is the pancreatic dehiscence causing grade B or grade C, or grade B leak perhaps, or grade C, you have to intervene with the patient in the grade C leak. Then if needed, you can convert the PJ into PG, or if it was PG, then you can convert to PJ. So that option is there, but by default, the first option would depend upon the surgeon.
The rates of PUPF are equivalent.
Similar, PG or PG.